Much everyone for joining in. Uh, this is the second chapter of Manthan, which is being done by ISMPO and is supported by AstraZeneca. To start, we have Dr. Sudeep Gupta sir from ACTRACT Mumbai, who will be opening the session.
Thank you very much, and good evening to all friends and colleagues. Um, and thank you to AstraZeneca for facilitating the second in the series of Manthan programs. The theme for today's meeting is advancing the care of patients with advanced and metastatic breast cancer. We know that breast cancer is one of the most treatable cancers, which has also seen significant advances in both diagnosis and treatment in the past few years. To bring everyone up to speed and to discuss the advancements in metastatic breast cancer, we have a renowned speaker today, Dr. Sunil Verma, uh, who was earlier in the academia but is now the Senior Vice President and Global Head of Oncology for AstraZeneca. He is a personal friend of ours. He also is an excellent speaker, has been involved in research as a principal investigator, has also uh, is now leading some of the programs of AstraZeneca. So welcome, Dr. Verma, and we all look forward to listening to you. And Dr. Verma's talk will be followed by discussions and other components of the program, and we will take that forward as we proceed. So thank you very much, and we can now proceed with the rest of the program.
Wonderful. Thank you so much, Professor Gupta. It's so wonderful to see so many friends. It has been a very long time since I saw many of you, and so good to see all of you doing well and doing great. So I think if somebody can upload the presentation, that would be great. And then we can get started. So it truly is an honor to see so many of you. It's been very long. It's been more than 4 years. And I must admit, I had to remember what Manthan stands for. And as I was looking at it, my Hindi is good, but maybe not as good as the word Manthan. It's really about brainstorming. And today I'll share with you how the brainstorming that happened behind the vision of the breast cancer strategy and how we're thinking about breast cancer care. And I'll also share with you a little bit of my own background and my own transition going from academia to industry and some of those learnings. Next slide. So as we think about what we're doing within AstraZeneca, so our focus is really at a 4-step approach. We want to really bring therapies which are going to transform survival. We want to make sure that we think about cancer in a very different way. And the word revolution was something that we really wanted to sort of bring forward, is because we can't just think about incremental gains. We have to rethink and redefine what cancer care and cancer research can look like. And part of this is we want to make sure that we improve the patient experience, not only just extend their survival. And then, of course, bring the people who are driven by this passion. And a big component of that was making sure that there's a patient voice, a clinical voice at the center of cancer research. And this vision was really the vision that I was inspired by. So going back to 2019 now, more than 4 years ago, it was in April when Jose Bazalga, who was the head of oncology at that time for AstraZeneca, reached out to me and said, Sunil, would you consider joining AstraZeneca? We can write the textbooks of breast cancer together. Next slide. So when I joined Jose, it was in the summer of 2019. Jose said, we need to think about breast cancer in a very different way. And we set forward with this strategy in mind in 2019. And this was a 10-year strategy that we put into force. We had a bold vision to indicate that we really need to change and help transform the practice of medicine and also the lives of patients living with cancer. And ultimately, we want to eliminate cancer as a cause of death for our patients with breast cancer. And there were 5 pillars to this strategy, and you'll see it shortly sort of coming through. One was understanding really which patients are at the highest risk of recurrence, both in the early stage setting to identify which patients are going to relapse, and also in a metastatic setting to say which patients are more likely to progress. We also needed to really rethink about the paradigm that we have to wait for patients to have clinical or radiological progression before we would switch their therapy. Can we institute a way that we can actually monitor patients through new modalities like ctDNA to understand who's at imminent risk of either relapse or imminent risk of progression molecularly and intercept the disease before there's clinical evidence of progression? We also needed to rethink how we were thinking about companion diagnostic to bring for patients with targeted therapies. And we had to think about it not from a drug perspective, but we had to think about it from a patient perspective, from a clinical perspective. And a big component of that was also how do we de-escalate therapy? How do we move away from the traditional pillars of radiation oncology and chemotherapy so that we start to think about how we can consider multidisciplinary care, but really in some ways forego the need of chemotherapy or really push chemotherapy to a very late line setting and replace chemotherapy with better treatments. And of course, how do we really rethink about immuno-oncology and what are the right partners for immuno-oncology? So next slide. So as we were doing this, I wanted to just reflect on a publication I did right before I joined AstraZeneca. And this was a presentation that I also shared at ASCO in 2019. And the presentation was that we have to redraw the lines of metastatic breast cancer. We can't think about metastatic breast cancer as a rigid process of first line, second line. And we also have to rethink the subtypes of breast cancer in order for us to really move forward in this field. So redrawing the line and redefining the subtypes became really sort of our first step to consider how we reconsider how we think about breast cancer. Next slide. So that led us to really, in the foundational strategic approach, start to think about what the paradigm of breast cancer needs to evolve to. And this is the original paradigm, of course, that we are all very familiar with. And we have to start thinking about that there's going to be multiple subtypes, but there's also subtypes that extend beyond different original thinking. So if we think about HER2 low, that really is seen and extends beyond the traditional hormone receptor positive. As we start to think about TROP2 expression, we start to think about that extends beyond the traditional subtypes. And as we start to think about when and how resistance evolves as a result of our therapies like ESR1, we have to start thinking about new ways of targeting and new ways of bringing new therapies. So this evolution in our thinking about redefining breast cancer biology, next slide, led us to bring this portfolio of studies. We went from 3 studies at that time to more than 25 studies. And I'll walk you through this somewhat of a busy slide, but really sort of thinking about how we are going to bring the next wave and really rewriting the textbooks of breast cancer. So the first focus, of course, on the top is from early stage to late line metastatic, different subtypes, as you noted there on the bottom. And then, of course, looking at different studies. And we recognized that there was an imminent need for us to think about evolving from going from the traditional first generation antibody drug conjugates to the next generation of antibody drug conjugates. So with our spirit of really our strategic pillar of replacing chemotherapy and displacing chemotherapy. And that led to, of course, in the HER2 positive studies, you saw the results of Destiny Breast 03, which in San Antonio, just this past year, we shared the PFS of 28 months versus trastuzumab with DM1, where, in Amelia, we had a PFS of 9 months. And this was really important for me. Of course, as you may recall, I was the principal investigator for Amelia in 2012, and I felt that we could even do more. So having and bringing a new generation of ADC and replacing TDM1 in the second line was an important focus to make sure that we bring a more transformative potential for our patients. And along with that, of course, now we have seen an improvement in overall survival as well. And furthermore, we wanted to make sure that we had an opportunity to see whether we can even replace our first-line treatment with taxane, trastuzumab, and pertuzumab. And we have ongoing studies in DESTINY-Breast09 in the first-line setting, and also DESTINY-Breast11 and DESTINY-Breast05 in the early stage setting. And what's remarkable of DESTINY-Breast03 is that in that second-line setting, we have 25%, nearly 25% of patients with a complete response. And this gives us the opportunity to start to consider what would that look like in the first line? And are there subsets of patients in the metastatic setting that we can truly cure? And this is a big ambition, and this is a big area of focus for us. And then, of course, the power of this ADC and our ability to think about targeting the HER2 receptor, but also thinking about the bystander effect, we started to reconsider this terminology called HER2 low. And we designed the studies with DESTINY-Breast04 to replace chemotherapy. And of course, many of you were at that ASCO meeting where we showed an improvement in progression-free survival, but also improvement in overall survival. And the reason for, I think, the standing ovation at that point was really that we are reconsidering how we can look at a receptor not only as an oncogenic driver, but as a receptor to allow us to really give targeted treatment to our patients using this mechanism of action. And of course, from DESTINY-Breast04, we are all eagerly awaiting the results of DESTINY-Breast06 later this year to think about, can we think about beyond HER2 1+, 2+ patients to also HER2 0+ expressing patients as well. Along the way, we also recognize the importance of TROP2 as a target in breast cancer. So that led us to do another partnership with our colleagues at Daiichi Sankyo in evolving and bringing forward datopotamab deruxtecan, or Dato-DXd, which is a TROP2 ADC. And this is being studied now in hormone receptor positive, as well as in patients with triple-negative breast cancer, both in the early stage setting and also in the metastatic setting. We also recognize that in addition to replacing chemotherapy, we have an opportunity to truly address and bring forward a next generation endocrine targeted therapy and SERD. And we accelerated a program with camizestrant, our next generation SERD. And you saw the data for SERENA-2, which was a phase 2 study showing a benefit over fulvestrant. And of course, then we expanded the program to SERENA-4, and I'm really proud of the design of the study for SERENA-6, which with our strategy, thinking of how we can intercept the disease by monitoring it at the occurrence of ESR1 prior to clinical and radiological progression in metastatic setting, we can maintain patients on either CDK4/6 and then switching the endocrine therapy from standard AI-based endocrine therapy to a next generation SERD. So that study is underway. And we also felt that there is a need for us to replace the treatment. And then, of course, we are bringing Cambria-1, which is in the early stage breast cancer setting as well. And along the way, we also brought olaparib, which is now shown to have improvement in early stage breast cancer with overall survival. And we also felt that there is a way that we can address resistance to endocrine therapy with an AKT inhibitor, and of course with capivasertib, where the results were shown for the San Antonio breast cancer with CAPI-291, looking at capivasertib plus fulvestrant versus fulvestrant. So this portfolio of studies really helps us now address across the subtypes, across the settings, and really redefines what breast cancer care is going to look like for years, if not decades to come. And I think part of this is really beginning with the notion that it starts with the patient in mind. Next slide. So what do we think about the future? In the next 3 to 4 years, we anticipate more than 10 new indications coming. We have already seen, at least by FDA, 3 approvals just this past year, and we're bringing more than 20 new indications by 2030. And this was really important with the aim and ambition to eliminate breast cancer as a cause of death. Next slide. So as we think about why is this important, it's important that we are able to do this for our patients. It's important that we do this in partnership with communities. And I'm really looking forward to how we can partner effectively with our colleagues across India. And it's also important that we do this to make sure that we perform to really realize the potential of the portfolio that we have. And I think we are making great strides. And I think I'm really proud of what the teams are delivering in this partnered approach. Next slide. But we have a lot of work to do. And this is just areas of focus for us. And we have to address still CNS disease. We have to better understand which patients are ER-driven and which patients are no longer ER-driven. What and how can we really cure patients with metastatic disease? How best do we sequence therapy? What are the right combinations of treatment? And how do we consider maybe re-challenge of therapies for patients that may have received that in the early stage setting? We also know that we have to continue to improve our patients' quality of life and address adverse events and identify which patients may be at risk of these AE events and which patients that we can actually help to address them if they happen. We have to continue to build on our strength of our biomarkers, including bringing forward our thinking about how we can integrate biomarkers. And we're doing a lot of work in the computational pathology space. And of course, how do we improve the patient experience on our therapy so that they can really realize the full benefit of our treatment? So I'm really proud of the work that we're doing, but the work doesn't stop here, and really looking forward to our continued effort together. And of course, bringing our therapies to make a meaningful difference for patients around the globe, including in India. Thank you very much. And I'm happy to take any questions that the group has. I know it's a tight agenda, but thank you again for the honor to be present here amongst all the colleagues and friends across India.
Thank you very much, Dr. Verma. As usual, you delivered a wonderful talk, and you took us through the vision that has shaped at least the strategy that you evolved at AstraZeneca about how breast cancer might be treated for at least the next decade, maybe beyond that as well. So does anyone have any questions?
Dr. Sudhir, good evening. Can I ask a question, Dr. Gupta?
Yes, Dr. Raja, by all means, please.
Thank you. I think as you mentioned, Dr. Sunil Verma, it is you captured the essence. Great lecture. Thank you so much. My question to you is that, we wonder, all the pre-existing data in the HER2 low field, you talked about destiny. That's why I'm taking you. And then there's going to be focus on, low HER2 and ultra low and all that. So, but I have a basic question. All the pre-existing data, wherein the effect of trastuzumab in the HER2 low patient, retrospective, some of them, and then the doublets, and then TDM1, and then even margetuximab, all of them did not show the efficacy that the deruxtecan showed. And I think if you look at the definition of low and ultra low, it is nothing but tweaking the pathologist. This spectrum of reporting has already been known. Nothing has been changed. The same platforms are being used. So it is not that they detected something totally different. And it's not that we are using an NGS and an mRNA to identify the HER2 enriched population completely different. We are not doing that. So therefore, my question is it that the payload, this is actually the irinotecan based payload, and incidentally, the efficacy is a TROP2 efficacy. So the success that we are seeing, is it due to the payload and the TROP2 being incidentally targeted? And we know very well that whenever HER2 is amplified, most of the time the TROP2 is also very close in the arrangement, and it is also most probably inevitably amplified. So I think, is this success completely success by serendipity? That's the question that I want to ask.
Yeah, it's a great question. Thank you, Dr. Raja, for answering that. And maybe for another time, I would love to sort of share the thinking behind the antibody drug conjugate chemistry in order to really get into the details as to why we think trastuzumab deruxtecan or Enhertu has a different mode of action. But to me, what really differentiated, I think to a point, whether is it the payload, is it the topoisomerase inhibitor payload? I think it may be partly the payload is very effective. Most certainly, it gives you the durability and gives you the mechanism of action. But I think what's most critical is that is the bystander effect. So what the preclinical data has suggested is that there is an ability for us, for when the drug gets into the cancer cell, it's able to actually transverse the cancer cell membrane and also affect surrounding neighbor tumor cells. So that's a really critical component, which does not exist with, of course, the antibody itself or with any previous generation ADC. So that was critical. The second really critical is that you have a stable linker. And that's important because a lot of time what happens is with drugs which have cleavable linkers, they get recycled out and they get pushed out within the cancer cell. And because it's stable, you have greater drug deposition within the cancer cell. So you may not need as much HER2 receptor expression as the traditional first generation ADC. So because of the stability of the linker, because of the bystander effect, we're seeing this. Now, what makes me more confident that this is really driven by not beyond the payload effect is we are seeing this across multiple tumor types. We're seeing this in breast cancer, of course, but we're also seeing this activity in gastric cancer and lung cancer. And of course, there was a press release just 2 weeks ago where we shared the data for Enhertu, at least the press release data, Enhertu in multiple HER2 expressing cancer cells. So this is beyond the payload, but it's really the receptor-mediated mechanism of action. Great question. Thank you.
So, Dr. Verma, I have a little different question. We have a reasonable number of patients who are triple positive, hormone receptor as well as HER2 positive. And traditionally thinking, we are giving them antibodies with chemotherapy as first line, and maybe with the mature data of Destiny trials, maybe ADC may be the first line therapy. But amongst those patients, can we identify some patients who are predominantly driven by hormones and we focus on the hormonal therapy rather than chemotherapy?
Yeah, great question, Dr. Desai. And I think it's something that we need to really understand which of these patients have truly ER driven. Now, everything that we have seen in early breast cancer and in late line breast cancer is in the co-expression of HR and HER2. HER2 plays a really pivotal role in driving that. Now, I think it also comes back to the burden of disease. If you have a patient who is older, has low burden disease, has bone-only disease, and is looking for a more convenient route, I think endocrine plus anti-HER2 approach is absolutely quite effective and quite stable for us to consider. For those patients who have high burden disease or rapid progressive disease or more aggressive phenotype of disease, I think this is where you would consider an ADC or a chemotherapy plus ADC as your initial therapy. But the biological manifestations to say which ones are ER driven and which ones are not is work that we are doing across the board to better understand what is the genomic profile that we can use as a gene signature to define ER predictiveness. And that is work that we are doing across our translational program.
Thank you.
Lovely talk, Dr. Verma, as usual. I have, in fact, two questions, if I may. Question number one is, what is the mechanism of action of the activity of TDXT in patients who are HER2 negative? Because in the DAISY study, you had about a cohort of patients who had a 35% response, though their PFS was shorter compared to the ones that were HER2 low by definition. Is it that the affinity is so great? Is it because of the tumor heterogeneity and hence a bystander effect? Or, is it that the expression is there, but you're not still able to pick up that expression and classify it as a HER2 low by the methods that we use now? And an extension to that, will there be a role in the future, or at least in your in one of your destiny studies, are you looking at the circulating HER2 receptors or something like that to better define a set of patients who classically would be defined as HER2 negative, but are likely to have some benefit from using TDXT? So what of this is the explanation for its activity in a HER2 negative patient?
Absolutely. Thank you, Dr. Senthil. Great question. And it's something that we are working very closely to understand. So I think there's a few factors. So one is the biology of HER2 expression. As you know, and I'm sure the pathologists know, that it's not a binary event. It's not a black or white. That there is, expression can be seen across multiple different cells, which may still be sort of defined as HER2 0 or HER2 negative, and may not be classified. So that's one. The second is, of course, intratumoral heterogeneity and intrapatient heterogeneity, that within the same patient, there may be multiple different areas that may have different levels of HER2 expression. So the biopsy that you have may not accurately represent the full picture. And then the second element is the testing. We're basing this on IHC. We know that there is no such thing as truly HER2 0. Even in those patients that are considered HER2 0, there is a certain level of HER2 expression that is seen. And this goes back to the pivotal data of trastuzumab in the early 1990s, that if you were to take a look at sort of fresh tissue expression before sort of the fixation elements that come into play with IHC, there is HER2 expression that is seen. HER2 0 still has about 10,000 HER2 receptors per cell. So we're looking to see for those patients who are HER2 0, are there ways to define better ways of defining HER2 expression? So the areas that we're really focused on, can we look at mass spectrometry to look at sort of the level of protein expression? And then can we also take a look at whether we can measure HER2 heterogeneity through digital pathology routes in order to say which one of these HER2 0 patients have HER2 heterogeneity that comes into play that may inform us as to what are those patients who are more likely to benefit. So in Destiny Breast 06, we have assessment of these patients beyond HER2 1+, and we will be assessing different diagnostic modalities to better understand what and how can we quantify HER2 expression in what was traditionally IHC-based classification of HER2 0.
Thank you, Dr. Sunil, so much for joining in spite of the time difference, I guess. Dr. Sudeep Gupta, sir, if you're there, thank you so much again for joining in spite of your busy schedule. We are a little running short of our agenda, so let's go to the next session, which is a mini podcast by Dr. T. Raja, who is a director of medical oncology from Apollo Hospitals, Chennai. And joining him will be two speakers, Dr. Devrat Arya and Dr. Sunil Pasich, I'm sorry. He is an oncopathologist and he is from RGCI Delhi.
So we are here to understand this new set of patients, so to say, that there is now a lot of excitement among all of us that now there are increasing possibilities, particularly with the advent of a more powerful drug, the ADC. And then now we know that we are able to treat population of patients which were previously considered to be not classical target of HER2-directed therapy, that is the low and ultra low. So my question to Dr. Sunil is this. This is the question that I asked Dr. Sunil Verma, and I'm now directing the question to Dr. Sunil Pasrika. Sorry if I'm correcting my pronunciation. We have been always aware that the HER2 reporting, if you talk to the pathologists, they would say that it's not like a real black and white reporting, and they were always aware of this spectrum of the HER2 scoring, and the scoring is not exactly very typical. There can be some differences and ambiguity. So what do you talk about that, and how much of concordance really happens just with the microscope level before we move on to the each testing and all? So can you address that inter-observer variation, Dr. Sunil?
Yeah. So am I audible?
Yes, you are. Yeah.
Yeah. So good evening, everyone. So as you have said that there can be issues for inter-observer variation, uh, but it's very rare because the guidelines are very crisp and we are using it for last so many years. So with a good training and with experience, I think the inter-observer variation has been till date has been very less. But yes, now coming with the concept of the low HER2 positive and the ultra low, where because initially we were not grappling with the 0 and 1 plus so much because ultimately they were both considered as a negative test. But now with these integrations coming in between that the criteria, the threshold criteria of the ultra low and the low HER2 positive, so the training has to be refined and that inter-observer variation that can arise that needs to be minimized. But as of now, till date, we are reporting there were hardly any inter-observer variations.
But then we heard about this retraining the pathologist, this particular. But if you look at our pathologists, who are most of the dedicated cancer hospitals, I think their level of reporting competence is all very well set, and we are still using the same Ventana. So I don't think there is anything called retraining. It is just that sensitizing them that there is an opportunity that we can treat them, these population more. So is that one way of looking at it, or you really think that there is some amount of laboratory retraining needed, Dr. Sunil? What do you think?
Yeah, because for the criteria for the ultra low that less than 10% of the tumor cells, because sometimes you get across the situation where you are on the just verge of that 10% cutoff. Because if you talk about 3 plus, so we rarely, although the guideline says that more than 10% strong complete membranous staining qualifies for 3 plus. But if you take the practical situation, we never get a situation, when we are grappling whether it is 10% or not. Once it is 3 plus, it is diffusely 3 plus. It's 80-90% it is 3 plus. So we never have that issue that the 3 plus that we are struggling whether it qualifies the threshold of 10% for 3 plus. But yes, for ultra low and 1 plus, sometimes you have a very heterogeneous staining, the low intensity staining, faint and barely perceptible staining, which is heterogeneous. So you have to take into the whole slide into consideration. You have to add up the different heterogeneous areas to make a final calculation whether the incomplete staining is crossing 10% or it is less than 10%, because we were not sweating out for this earlier.
So, the third question to you before I turn to Dr. Arya is this. Dr. Senthil touched upon this. How would a completely so-called HER2 negative would be a candidate, and what is the mechanism and bystander and all that is being described? But at the level of pathology, we have already known that, Dr. Sunil Verma did address that there is something called heterogeneity within the tumor and then within the patient. So we also know that when we want to assess the biopsy for HER2, the core biopsy is probably the best, even over and above the whole specimen and so on and so forth. So when you are given what is your pathologist's instruction to the clinicians, including the surgeons, with arriving at the best possible sample for you to assess HER2? Can you tell us, Dr. Sunil?
So, this question was to me, sir?
To you, Dr. Sunil, that, with regard to the heterogeneity,
right?
That's what Dr. Sunil Verma answered to Dr. Senthil's question.
Right.
So within the patient, and then the sample, we know that between the specimen and the core biopsies, so those issues about the heterogeneity, that's what I want you to touch.
So definitely both has advantages and disadvantages. Like the most advantage of the core biopsy, as you said, it is best, but it is best only because it has a very optimal fixation. What happens is that a person is taking the biopsy, so there is no cold ischemia time issues in the core biopsy. The moment you take the sample, you immediately immerse into the 10% neutral buffer formalin. So the fixation is very much optimal. But that can be taken care of even in the resection specimen. But because the resection specimen has advantage that you get to see the area which is more than 10 times or 15 times, you can more area can be assessed in the resection specimen. But for that, one has to really take care of the cold ischemia time. And so the immediately whenever, so like we have maintained a logbook, like whenever the specimen is received from the OT, and we immediately put the time, and immediately we bisect the tumor and immerse in the formalin is also changed, and we put it into 10% neutral buffer formalin. So if cold ischemia time is being taken care of meticulously and diligently, so I think the resection specimen definitely has an advantage that you are able to assess more than 10 to 20% more area. Because the heterogeneity will be taken care of more in the resection specimen rather than in a true cut biopsy.
Thank you. That's a very important answer. I'm asking Dr. Arya. Dr. Arya, we heard Dr. Sunil Verma that why this drug is so powerfully different before, as compared to the previously available targeting agents. So what is your thought, and can you explain why this is so important change, whether it is the cleavable linker and whether it is the payload and whether it is the bystander effect? Can you tell us what exactly is making this drug different from the previously available options?
So I think there are two aspects, and I hope I'm audible.
You are, yeah. Thank you.
So I think two important aspects. Okay. First of all, as you were discussing with Sunil, I think from a binary classification of HER2/neu, from a HER2/neu positive to a HER2/neu negative, and you yourself asked this question as to how trastuzumab, pertuzumab, and of late margetuximab actually did not have any effect. We increasingly are dividing our patients into 3, perhaps 4, and perhaps eventually a very dynamic classification of a HER2/neu positive, HER2/neu low, HER2/neu ultra low, and one day probably there will never be HER2/neu 0. And what this drug lets us do is we already have the data in HER2/neu positive, but an increasing subset of patients are actually candidates for this drug on account of even a very low HER2/neu expression. I think that's one difference. The other thing is that clearly HER2/neu is a biomarker, and when it's expressed, the antibody is able to bind. And obviously, you've shown the cartoon. The combination is going to be internalized in the lysosome. It will break up. The TOP2, which is the toxin, is going to be released. It's going to damage the ipsilateral cell. It will also damage the neighboring cells, which may not actually be expressing HER2/neu at all. And we saw to some extent with TDM1, it's something similar. But the fact that you have higher drug to antibody ratio, and that's what the description has been. It's 8:1. It's very stable within plasma, which lets it be very safe otherwise. But once internalized, it's easy to cleave. And so some of these hypotheses are what are propounded as why this drug, as a second generation ADC, seems to be very effective in this subset of patients. Clearly, I think data seems to suggest that it's quite active. We all are aware of the results of Destiny Breast 04 in all subsets, including triple negative, or I should say ERPR negative and HER2 low. Even there seems to be what is a clinically meaningful improvement in progression-free survival and overall survival. So clearly, I think it seems to be a very good option.
Thank you. So before I move back to our pathologies, I have one more question to you. Why, we heard about the fish, and now we are all transforming to the new platforms. Ish and Sish and all that. One turnaround time is so quick and so convincing, and so on and so forth. But why is it that we have not involved NGS and mRNA to identify these patients? And we have already known that finally we can identify the HER2 enriched patient by the mRNA level. So why was that never considered in any of the clinical trials? Or what is your thought, Dr. Arya?
I think generally we've tried to look into the easier to do, less costly modalities. I think that's what we'd end up doing in a real world practice. NGS obviously seems fairly accurate, but the problem with NGS is the turnaround time, and it's usually bigger. Now, I do remember a statement that was made in one of the SABCS debates. Some of the current IHC platforms, especially for a HER2/neu very low setting, seem to be, an attempt to weigh mice on a scale built for elephants. So I think that's the HER2/neu very low. But I guess we have to identify a platform that is cheap, easy, and has a very quick turnaround time. And whatever will be that platform, I think that's what we'll have to use.
Coming back to Sunil, sir, we heard a presentation recently that the new platform CISH will transform the turnaround time to 24 hours and so on. So what is your practical advice in your institutes? Are you switching over? And can you tell us about that particular issue?
So as far as the turnaround time is concerned, so like if we are getting a equivocal result on IHC, we have a reflex code. So immediately we don't advise for the fish. We have the reflex code, which what we are charging from the patient. So immediately the test goes immediately for the fish testing. And within 2 days, we are ready with the fish results. So as far as the new technique that has come up, that is a CISH, that a chromosome in situ hybridization. So yeah, that reduced the time, you can say, by 24 hours. But that, I mean, even if we are continue ahead with the fish, doesn't make a much difference in the the patient management, like just having a turnaround time of 2 days or 3 days. But NGS,
is the efficiency different between CISH and the fish? Finally, in the pickup and all that?
No, because many studies that has been validated, like we have seen, they are validated on the fish only. So they are equally good. I mean, there's nothing that they are more. The only the advantage of CISH is that when you are doing the CISH, so in the chromosome in situ hybridization, you can be aware of the histomorphology also. Like in the fish testing, when you are evaluating the signals. So in the fluorescent microscopy, you are not able to assess whether you are evaluating the DCIS component or the invasive component. But when you are evaluating CISH, in that you will be able to evaluate the morphology as well along with the interpretation. So you will be able to discriminate whether you are evaluating these signals in the DCIS component or in the invasive component. So that's definitely an added advantage of CISH.
Is it true that the Tata Hospital has completely switched over to CISH?
Yeah, they have.
Correct. Yeah.
They have started the CISH, and recently there was a presentation also. Talk was given by Dr. Sangeeta.
Rajiv Gandhi has also switched over. Is that correct?
No, we are still continuing with fish only.
Okay. So Senthil, with that, I stop and give it back to you. And thanks for allowing me to do little indulgence. Thank you.
Thank you. They're always a pleasure. And again, sorry for interrupting. I hate to do that, but that's what the information given to me was. Anyway, never mind. Always a pleasure to listen to all of you. We'll quickly move on to the case presentation sessions. So we have 5 cases to be presented. We've got a panel of experts, and the experts include Dr. Ullas Batra from Rajiv Gandhi Cancer Hospital, Dr. Manish Singhal from Apollo Hospital in Delhi, and we have the third expert, who's our own Dr. Chirag Desai from Ahmedabad. So we'll plan it this way. We'll give about 10 minutes for each case. My request to the presenters is, please keep your presentation short. Because I went through the presentations, all of them are lovely cases, but I saw that, some of these cases have about 8 to 10 slides. So if you minimize the time taken for presentation and have a couple of points that you would want the expert to discuss upon, that will be really great so that we can gain the maximum and also go back wiser this evening. So can I ask the presenters to start? So in which order would you like to start, Sana? Should we start from Rajiv Gandhi itself? I can see Ullas on the screen, so it'll be great to start with the Rajiv Gandhi Cancer Hospital presentation. That's the one I received last. That was at 10 o'clock last night. So we'll start with the last one.
We were told that our presentation is number 3. The guy has just gone to have tea.
Whoever number 1 has been
designated.
Okay, here.
Never mind. Never mind, Ullas. Anything for you? Sana, if you can...
Yes, Dr. Padmini Sen, if you can start presenting.
Great.
So good evening, one and all. The first case for today is a case of metastatic globular carcinoma of breast, hormone receptor positive, HER2 new low. So this was a patient, a 46-year-old premenopausal lady who presented us with generalized bone pains in October 2016. So she had undergone an MRI spine, which showed multiple bone lesions. And also, incidentally, we picked up a right breast mass. So this mass was biopsied and came back as infiltrating globular carcinoma grade 1, ER positive, PR positive, HER2 new 1+, and KI67, 15 to 20%. So she was diagnosed to have metastatic lobular carcinoma breast with bone secondaries, and she was planned to start on palbociclib and letrozole. This patient also had menorrhagia secondary to uterine fibroids, for which she underwent hysterectomy and salpingo-oophorectomy. So subsequently, she was started on palbociclib, letrozole, and monthly denosumab, on which she did well, and her bone pain significantly reduced after 2 cycles, and her PET-CT scan after 3 cycles showed metabolic resolution of the bone lesions. So she fairly tolerated this therapy well. And what was remarkable is she was on it for 37 months with a very good quality of life. And all her interim scans had shown no active disease. In November 2019, she again had started developing the pains, and on reassessing, what we found was the bone lesions had again become active, but however, there was no soft tissue lesion that we could biopsy. So at this point, we went for a blood NGS testing, and what we found in it was this patient had ESR1 mutation and also PIK3 mutation. So now we looked at what can we do next. So that's when we started her on fulvestrant and alpelisib. And like we know, the common side effect, our patient also developed hyperglycemia within 2 weeks, but it was quite manageable. And with metformin, she did settle down, and with 1 dose modification. So after 3 cycles, as we can see, she had a complete metabolic resolution of the bone lesions, and she was continued on this. And what was again amazing is that this patient tolerated the medicine and did well for a span of more than 2 years, with the interval scan showing no new lesions and no activity in the bone lesions. So in Jan 2022, she presented with pancytopenia. At this point, when we reassessed her, we found she had multiple liver mets, and the bone mets had become active again. And also she had some serosal deposits and peritoneal lesions. So at this point, considering the pancytopenia, we also did a bone marrow biopsy, which showed infiltration by the cancer cells, and molecular testing showed ER positive, PR positive, and HER2/neu1+, and Ki67 of 40%. She also had some headache, so for which she was evaluated. Her MRI brain showed pachymeningeal enhancement, suggestive of metastasis. Now, this got us thinking. So now here we had a patient with low counts and progressive disease. So what can we do more? What do we offer her next? So after detailed discussion, we planned to start her on chemotherapy at this point, and she was started on epirubicin. So after 3 cycles of weekly epirubicin, the interim scan showed the lesions were stable, and clinically she was doing better. Her counts recovered, and she became transfusion independent, and the bone marrow was in remission at this point. So she was continued on the same medicine, and she went on to do well till July 2022. And the repeat scan showed partial response as well in the lesions. And at this point, we were worried that we were nearing the cardiac dose. So we subsequently started her on nab-paclitaxel weekly regime. So again, when we repeated her scan 3 months later in September, though clinically she was fairly doing, she was tolerating the chemotherapy well, except for some peripheral neuropathy. The bone scan, the PET-CT showed again activity in the bone lesions and the liver lesions, and there was interval increase in the previously noted lesions as well. So at this point, so here we had a patient who had progressed on multiple lines, and she had gone on with the treatment for 6 years. Now, at this point, we were worried, what can we do more, and what can we offer her? So that's when, so based on the Destiny 04 data, considering this patient had HER2/1+, we decided to start her on TDXD, trastuzumab deruxtecan. So she was started on this from October 2022. And after 3 cycles, when we reassessed her, what we found was the activity in the lesions had come down. She had metabolic resolution. Clinically, she was better and she was tolerating the medications quite well. So she has been continued on the treatment, and so far she's received 8 cycles and continues to do well. Thank you.
Great presentation. A very nice demonstration of how you can take your patient from one therapy to the other. Do our experts have any comments to offer or any questions, any points to discuss? Or Padmini, would you like to ask some question to our experts? Or if Amit is around there, I'm sure he has something.
So, Santil, if I can start.
Yeah.
What I feel is that as an expert in this session, we will be deliberating on what extra or what else we would have done for this patient. So I thought that the NGS was done and it must have covered BRCA mutation, but I would have additionally done BRCA mutation by MLPA as well. That could pick up few additional patients with BRCA mutation, and that could have been offered a PARP inhibitor at that point in time. That was first thing. Second thing was the patient in January 22 presented with Pecci meningitis along with the pancytopenia and liver metastasis. And I didn't see any CNS directed therapy, whether it was given or not. And if it was just with epirubicin weekly therapy, if she responded in the brain as well, very good. I mean, congratulations, your patient did very well. So that was the second thing. And third thing is that I believe Nab-Paclitaxel was given as maintenance therapy, right? So in maintenance, rather than Nab-Paclitaxel, I mean, it's a debatable issue. I'm entering into the hornet nest, but I would have either stopped treatment or I would have given oral metronomic therapy at that point in time. So these are the few points which I noticed in this patient.
Great. So Amit, MLPA, pachymeningeal involvement, was something done about it? And then why did you decide to do maintenance Nab-Paclitaxel?
Yeah, excellent points, Dr. Chirag. So one BRCA germline was tested. So that's something we didn't mention. It was tested. And actually, this patient has had a sort of a serial testing of blood NGS done at each progression. And we have seen how the ESR1 clones, how they've changed and how the PIK3 clones changed with treatment with alpelisib. So this patient has taught us a lot. She's taught us about how the CDK4/6 works, how PIK3 inhibition works, and how the further treatment can be taken further. One very good point which Dr. Chirag brought out was this epirubicin, and that was a very controversial thing. When she had marrow involvement, that's the time where we were almost sort of giving up. And that's the thought. With pancytopenia and low platelets, we had decided anyway we will not do any CNS-guided treatment, especially IT therapies and all that. We had decided we can't do much. There was the point where a question was, can we offer her directly Enhertu-based therapy? And that question, we put it up with quite some experts in the US, and all of them said, Enhertu is approved after 1 line of chemo. So you have to offer some chemo. And they also said there is no data of using Enhertu with very low platelet counts. So the risk was too much. So eventually a lot of discussion was done, and we put her on weekly Anthrax, saying probably this is the safest to do, but she showed a response. So we were very happy about it. We did offer her oral capecitabine post this. That would be the way I would have taken this forward, but she just didn't have a tendency to take anything orally comfortably. And that's the reason why we chose Nab-Paclitaxel. But what surprised me was so we've read about the TDXD data. It's absolutely there. But when we see HER2 1+, I really thought it will not work. I was not sure whether it will really work or not. With clear liver mets progressing, that's the time when we would have talked to her about some alternate chemos. But the data is there, and we have read so much about it. So we said, no, we should give it a try. And that's where we saw that amazing response. In 3 cycles, all the liver mets just shrunk off. And I believe TDXD has CNS penetration also. We've seen so much data now. We've seen the prospective tuxedo data also showing that TDXD works in the brain. So I think that's what's helping her in the brain rather than anything else.
Lovely. So lucky patient, it looks like, Amit. And there's Tuxedo, and then there's Deborah, and all these studies which are showing some excellent CNS activity. But very important points made. I think we need to keep in mind, be cognizant of the fact that TDXT is myelosuppressive. So it can cause neutropenia, not so commonly cause thrombocytopenia. So, Amit made a very important point there that they were a little apprehensive in using it in a patient who had marrow metastasis. We always then feel, when you talk to somebody in the US, they're very sure about sticking to the labels that you have to have one line of treatment, you have to have 2 lines of treatment. But, in a way, we are better that way. If you want to push your treatment up, you could do it depending upon what that clinical situation might be. So very good learnings from this patient, I suppose. Quick point, Manish or Ullas, before we move on. Is there anything that
I didn't hear we didn't get the connection, but I just wanted to ask, was the tolerability of TDXD? We have been doing a Destiny Lung and Destiny Breast, and for us, diarrhea is a major factor, and weight loss also is a major factor. And the first and second cycle is usually very difficult. So in this patient, how was the tolerability?
Amit?
She tolerated very well. There's really no issues, but we have had another patient where we have had to dose reduce. So I think as we start using more and more, we'll try to understand. But eventually, we do need to understand it is chemotherapy. So diarrhea could be a problem, neutropenia could be a problem. So we need to be careful about it.
Yeah, because in our, all the 3-4 patients, 4 in the breast first line and lung, the first one that we have had to dose reduce approximately 3 or 4 of them. The drug is wonderful, but I think the 5.4 doesn't really suit the Indian people. I think we have to go to one level down. That's the thing. Dr. Doval has a point.
Maybe it is the tumor type that we have to see, because I have tried it in Destiny 6, Destiny 7, Destiny 11, and we did not have to reduce. Hematological toxicity was not there. Weight loss is the main.
Weight loss.
Okay. So Ullas, we are happy that at least we didn't follow your lung data of 6.4 initially.
6.4 can be really whopping. In fact, we had a patient with stomach where we decided not to use 6.4. We did 5.6. Okay, but ultimately the patient succumbed at some point in time. So I think we'll move on. As they say, this is targeted chemotherapy, if you can use a term like that. So that's what all these ADCs are, because they're carrying a toxin, they're carrying a chemotherapy, and so on. Okay, we'll move on. Thanks, Amit, and everyone from Manipal. We'll move on to Dr. Atira. Atira, can you keep your presentation short so that we will have more time to discuss? And if the next person, Dr. Anindya, can be ready with the presentation.
I'll be presenting the case of a 54-year-old female with no comorbidities and having a performance score of 1. She presented in May 2018 with right breast lump of 3 months duration. And on examination, it was a 5 × 5 centimeter lesion in the right upper quadrant with 2 × 2 centimeter mobile right axillary node. And her systemic examination was normal. No abnormality was detected, and biopsy showed infiltrating ductal carcinoma, grade 3, and right axillary lymph node FNAC showed positive for malignancy, and it was an ERPR negative, HER2 negative disease, and PET-CT showed no distant metastasis. She had a right supraclavicular lymph node, and the staging was C T2N3M0, carcinoma right breast, IDC, grade 3. And her case was discussed in tumor board, and she was decided for neoadjuvant chemotherapy. And from May 2018 to November 2018, she received 4 cycles of AC, followed by 4 paclitaxel, which was dose dense. And she had a clinically very good response. And she underwent right MRM, and his HPE came to be IDC, grade 3, YP, T1A, and 3 in November 2018. And she underwent adjuvant RT, 50 grade, 25 fractions. It was completed in February 2019, and she was on adjuvant capecitabine, completed 8 cycles in July 2019, and she was on surveillance from August 2019 to January 2020. And in January 2020, she had a right axillary swelling and a backache, and PET-CT showed right axillary soft tissue thickening, a liver lesion, cervical and abdominal lymphadenopathy were a new finding. And the liver biopsy showed poorly differentiated carcinoma, ERPR negative, HER2 negative. and her germline BRCA12 was negative. And the PD-L1 testing by SP142 was 5%. And it is a PET-CT. It is showing lesions in the liver, infraclavicular node, abdominal lymphadenopathy. So she was started in February 2020 with chemotherapy nab-paclitaxel day 1, day 8, day 15 with atezolizumab 840. And till July 2020, she received 6 cycles and she had a very good response. PET-CT showed stable disease. And we continued the therapy. And in November 2020, she received 17 cycles of atezolizumab and the PET-CT was showing a stable disease. In January 2020, she completed 22 doses and the PET-CT was stable and she was clinically doing very well. PET-CT was showing a stable disease as per IRIS criteria. And her therapy got interrupted for 2 months due to COVID and it was restarted in June 2020. And in July 2021, she completed 27 doses of atezoli and the PET-CT showed it showed progression and increase in mesenteric lymphadenopathy, but she was clinically stable. So what should be the next line of management? Should we continue atezolizumab? Should we do an NGS? Or should we start with sacituzumab? Or we should do a repeat biopsy, HER2/neu, and if it's come to be HER2/neu low, should we start TDX?
Okay, great presentation, Dr. Atira. Can we start with Manish? Manish, do you have any points to make?
No, sir.
Manish not there. So back to Chirag and Ullas. Ullas, you want to suggest what the next step should be? A rebiopsy and an NGS, get to sacituzumab, continue atezolizumab?
So I think rebiopsy is definitely in order. I mean, with immunotherapy and especially with mesenteric lymph nodes and all, I think we have seen enough and more number of times that it could be a granulomatous inflammation or a reactivation of tuberculosis. So one thing I'll definitely do is probably do a rebiopsy. Send it for NGS. Yes, I mean, the disease is following a very atypical, not atypical, but I will send it for NGS also at this particular time. Whether I'll act on that NGS or not is a separate question altogether once we get the NGS report. Again, take a call at this particular time whether this can fall into an oligo progression. Maybe if it can fall into those lymph nodes portal, take a radiation oncology consultation. If it follows into one portal in which we can give radiation to that and continue atezolizumab after that. So that's the thing. But yes, rebiopsy first, definitely.
So rebiopsy shows triple negative, Ullas, and then it can't be encompassed in one portal. Toxicity, what do we do?
Okay. So, and the patient is asymptomatic.
Patient is asymptomatic.
And what is the volume of disease?
Okay, all over the abdomen lymph nodes. It's mesenteric lymph nodes.
Okay, next line of treatment then. If the patient is becoming symptomatic and the immunotherapy is progressing over there, not encompassed, I would like to send an NGS and change over the treatment.
Okay, NGS most of the time will show you a PIK3CA mutation. That's what happens.
And then don't act on that.
3CA is the question.
Don't act on that.
Okay, lovely. So what's the next therapy?
So sacituzumab govitecan is absolutely okay. One thing which I might again do is sacituzumab govitecan is okay till the time patient gets that. Continue with atezo and re-challenge with nab-pacli also.
Okay.
Patient did respond very well over there. So, stop, start thing also is something which I may do.
Yes.
Patient will take some 2-3 months to get, in my center, will take some 2 to 3 months at least to get this. Till the time, add Pacli again, give atezo Pacli, reassess in 2 months' time, and then see how is it really going from there.
So that is based on your judgment.
Nothing. That is based on nothing, actually. Okay. I mean, that's something because the patient really responded to Paclitaxel at that time, had a good response to liver. You don't know how sacituzumab going to act. So
correct. So since it's been a long duration from the last nab-paclitaxel, it may be worthwhile re-challenging, especially in a situation if you don't have any other options that you can fall back upon immediately. But as was pointed out by Dr. Atira, I think sacituzumab will be the best option at this point in time because single-agent activity of any other chemotherapy or even dual chemotherapy will be somewhere around 20-25%, not more than that, while the response rate and the PFS that you get with sacituzumab is much more than that. It's about 30-35%, which is much better. So if you can lay your hands on that, that will be a great treatment. But it would not be wrong to use something like capecitabine or some of those drugs because it's just an indolent progression, if you can call it that way. It's not that rapid progression with disease shooting through the sky and all over the place. So it would be perfectly all right to do something like a metronomic treatment for some time before you see significant progression, and then you want to go on the so-called better drug at a later point in time. Chirag, any points that you want?
Before, one second, Senthil, before going for metronomic, I would rather do oral capecitabine full dose 302 or 303. Not OMCT. Probably OMCT will reserve for later on when it's really an OMCT thing.
Point well made, Ullas. When I said OMCT, I was talking about capecitabine, not
anything oral is oral OMCT, Senthil.
Yes, correct. You're getting there, right? So when I meant metronomic, I meant capecitabine at the regular doses, not at the metronomic doses of capecitabine. You're right. Because you would get a response rate of somewhere around 12-14%, which is not bad for somebody who's got an indolent mesenteric nodal progression. I think that's perfectly all right. Chirag?
I agree with the comments by Ullas as well as your comments. Additionally, I would want to rule out second primary in ovary by the next biopsy. That is one thing. And if I'm pushed to give chemotherapy, I think carboplatin gemcitabine will be a good option for this patient.
What we would
of course, capecitabine is there, but carbogemcitabine also would be a good option.
Correct. Whenever it's triple negative, we are tempted to use carboplatin in a place like that. That's absolutely well taken. So we'll wind up this case. I think just one point: when you're doing PD-L1 by SP142, it's not expressed as a percentage. It's usually IC or TC. When you're talking about the use of atezolizumab, it's for patients who have an IC 1, 2, or 3. So I think you made a typo error in your slide because it said 5% or something like that. So just get back and then look at that, because SP142 is never measured as a percentage. So that's just another learning point for all of us here. Thanks so much.
Okay. If I can interrupt for a second, for SP142 for metastatic breast cancer, triple negative, it is IC at least 1%.
That's right. It's IC1. It's not percent. Yeah. Just a small correction, Chirag. Thanks. Thanks.
One more point till the time the next slides are being put up. Can I make a point? And please make up the slides for the next one. Yes. We had a similar patient in which we gave atezolizumab for around 48-50 cycles. And then what do we do? The Roche has withdrawn the drug. What do we do now? Similar patient like this, atezolizumab for 50 cycles, something she has taken. Stop atezo, continue atezo, just asking.
So Roche has withdrawn the drug for that particular indication, but then the drug is still available, isn't it, Ullas?
Yeah. So costly.
Costly. It's going to say by then the patient's pocket would be empty and it'll be time to send her home, right? No.
So I'll just tell you, we have stopped after, same as this thing, we have stopped after 2 years. So till that one more year has elapsed, nothing has happened. So I don't know when to stop actually, and can we or can we not?
I don't think anybody knows the correct answer to Ullas. So
we stop sometime.
With all our patients who've been on immune checkpoint inhibitor for a prolonged period of time, right? Dose decrease, widen the frequency, here and there and everywhere. So that's what we keep doing most of the time with these patients.
Yep.
Thanks, Ullas, for that very important point. Can we move on to Anindya?
Good evening, teachers and colleagues.
So, Anindya, I know you've got plenty of slides, but I want you to quickly run through it so that we can discuss your CNS.
Yes, sir. Just 2 minutes, sir.
Okay,
46-year-old lady with just comorbs of the hypertension and hypothyroidism was detected with a lump in July 2019, which was followed up with a biopsy, and then left MRM was done in September 2019, which showed a PT2N2A invasive breast cancer grade 2 and ER 10% PR negative and HER2/neu, which was amplified on FISH. So following this biopsy report, we gave 6 cycles of this adjuvant TCH regime, followed by that post-mastectomy radiotherapy and then trastuzumab with hormones. Next slide, please. So after this, patient was on this adjuvant hormone therapy. So roughly around 1 year after the surgery, patient had a recurrence. That was an exclusively intracranial recurrence in the right frontal mets. There was no extracranial disease. So we usually do both the PET scan and the MRI brain. So the disease was detected only on the MRI brain. Following this recurrence, isolated CNS relapse, there was a right frontal craniotomy for the removal of the lesion, and thereafter an SRS was done. Again, the biopsy showed it is of the same. The histopath, the type, the ER is 10%, PR negative, and HER2/neu +2 amplified on FISH, similar to the primary lesion. So we started with lapatinib and femora along with ovarian suppression with Zoladex from April 2021, and patient showed up with no extracranial disease with just gliatic changes in a follow-up scan in August 2021. Next slide. So after DFI of 14 months, patient again had a intracranial disease relapse, which was shown as this right frontal disease progression along with the bilateral midfrontal and the paraphyseal regions, with also leptomeningeal involvement that was confirmed with CSF cytology being positive. So the options were given of TDM1 versus lapatinib capacitinib in combination or distucatinib. Patient opted for the second one, and we gave lap plus cape combination along with, because of the cytology positive, we started with intrathecal methotrexate. That was started in January 2022. From March, we shifted on to TDM1 and ITMTX was continued. May evaluations showed that the disease was under control. And although the CSF cytology was persistently positive across till August 2022, for which the ITMTX was being continued. Next slide, please. Patient had a third recurrence after a DFI of 8 months. Again, only the disease progression was intracranially. The PET scan showed there was no extracranial disease. So by this time, patient had already completed 9 cycles of the TDM1. Following this intracranial further disease progression, we took an opinion for the radiation oncologist, and this whole brain radiation was given in September-October 2022. The latest cytology in February is showing still atypical cells, and patient has presently completed 15 cycles of TDM1 as on 15th March. She is doing fine with no CNS symptoms with an ECOG PS of 2. So this is the representation of the intracranial disease progression. So there was a first recurrence in November 2020. Thereafter, there were gliatic changes. That is, the disease was under remission in August 2021. A second disease progression in January 2022. And then again, a third disease progression in September 22, following which the whole brain RT was given. Next slide, please. So the questions to the board is, what is the ideal systemic therapy of choice after an isolated intracranial disease relapse, post local therapy like SRS was done in this case, in case of HER2 positive metastatic breast cancer? And what would be the ideal treatment for a leptomeningeal disease with CSF cytology positive in HER2 positive breast cancer? And what exactly are you looking at when you are going to treat the intracranial disease? Is it the overall response? Is it the duration of the response? Or is it the PFS or the overall OS? So these are the landmark trials and also the intracranial response rates along with the PFS and OS. This has been shortly tabulated for easy reference.
Chirag, would you want to start?
Yeah, so well, this patient did very well. She was very fortunate to have a good quality of life for a long time, for almost 15 months since a development of CNS metastasis, rather leptomeningeal metastasis. So systemic therapy of choice after isolated intracranial progressive disease, the dictum is that don't change your systemic therapy if there is isolated intracranial progression. Just continue with the same systemic therapy. So that is the dictum. We can change according to the situation, patient to patient, but in general, this is what we do. Ideal treatment for leptomeningeal disease, there is nothing like ideal treatment, nothing works. In your case, it worked, so that was good. But in next progression, be prepared to give her TDXD, or if the patient is symptomatic, try to procure tucatinib. That works better in the disease who are the patients who are symptomatic. And aim of treating intracranial disease is everything. I mean, we want to have response for a long time. We want to have good PFS as well as we want to have better survival. But I think the most important thing for this patient is to maintain the quality of life. So that's most important thing.
Chirag, I just want to go back to question number 1.
Yeah.
Question number 1 is, so in this patient, when the brain failure happened, patient was systemically clean and she was not on any treatment at all. Right. So this was after the initial period that, this relapse in the brain happened. So let's say somebody has had adjuvant treatment, for example, and then 1 year later, you find that there is progression in the brain, somebody like this, and then you have removed that metastasis by surgery, and then you've probably done SBRT. In that situation, would you add another anti-HER2 drug, or would you just say, I have taken care of the CNS with surgery and radiation therapy, there's no systemic progression, so should I observe this patient without any further anti-HER2 therapy, or should I put this patient on some anti-HER2 therapy? I think that's the question that Ullas is trying to ask in this particular patient.
So if you go by the books, if you go by the guidelines, don't start any new therapy.
Correct. So,
but in this particular patient, it was just 1 month after completion of trastuzumab. So if it is happening so soon, we will be tempted to give some treatment to this patient.
So it's a temptation to do it, but as you rightly pointed out, the guideline would say that if you have the CNS and there's no disease anywhere else, we would not rush into starting some systemic therapy. So that's fine, but I think Ullas had his own reasons to start this patient on lapatinib. That's perfectly all right, because at least we believe that TKIs are better for the brain compared to the antibody drug conjugates, because the penetration is likely to be better. Ullas, my question for you would be, you put this patient on lapatinib, and then when the patient failed again in the brain, you added capecitabine to lapatinib. What was the thought process there, Ullas?
The thought process was only the LAP and Femara was not working. TDM, the patient was not affordable. TDXG was not there. Tucatinib was not there. Capecitabine could have crossed the blood-brain barrier. So that was the only thing.
So you just, put that 2 and 2, lapatinib, capecitabine there.
Yeah.
They are the usual partners, so you added capecitabine to see if there was some CNS activity.
Yeah.
Well taken. Any one of you have, one of the questions put up there is treatment of leptomeningeal disease. It's a very difficult thing. Even tucatinib and TDXT only have a handful of patients with leptomeningeal disease in all those studies that we are quoting here. So we really don't know the activity of these drugs in leptomeningeal disease. We don't have large volumes of, I'm reminded of Bloom study. Ullas will, immediately, recognize what the Bloom study is. 7 patients with leptomeningeal metastasis and osimertinib. That was the first study that we heard about osimertinib and brain metastasis. I think over time we will have more data, but it's limited. But my question to both of you is, have you had any experience with intrathecal trastuzumab? Because there's some data from Tata Hospital, 3 patients. We had 1 patient that we used intrathecal trastuzumab. As always, in their hands, it seemed to have worked reasonably well. In fact, there was a patient who went on to have intrathecal for nearly a year or more. But in our hands, it didn't work. The only patient that I tried, succumbed to the disease very soon. So what are your thoughts on intrathecal trastuzumab, Ullas and Chirag? Quick comment before we move on.
I think the first time intrathecal trastuzumab came, that data was from Australia, and the trastuzumab they were using were preservative free. And at that time, we didn't have that trastuzumab. Now we have that. My plan for this patient actually is to give IT trastuzumab once she fails next time, because tucatinib she is not able to afford. TDXG also is going to be very costly. So in this patient, yes, I'm very tempted to use that. I think one patient, Senthil, as you rightly said, can be here and there. But I think it should work. I mean, let's give it some more time, some 8-10 patients. It's almost like nivolumab in second, third line. You need more people to really make up your mind.
Don't have any choices and you're desperate, you're willing to do everything. I think that
it will be called not intrathecal, but desperate trastuzumab, I think.
Desperation trastuzumab. Okay. Yeah. Well, Chirag, do you have any experience and what are your thoughts?
No. I heard the data from Sudeep's group about intrathecal trastuzumab. Never done that. And I would want to look at the experience of all of you and then I will put it in my practice.
Okay, so you'll wait for us to burn our fingers and then you will...
You get very desperate.
The most experienced it looks like. Okay, lovely. So the point here is 2 important learning points here. One is, as Chirag and Ullas rightly pointed out, CNS is under control. You've eradicated, at least radiologically, the disease in the CNS. There's no clear role for addition of systemic therapy if there's no systemic failure. That's point number 1. Leptomeningeal disease is very difficult to treat irrespective of what the primary is. There's very limited data with tucatinib, TDXT, lapatinib, and all of these drugs that are supposed to penetrate the CNS. Radiation is not the best choice treatment. So that's the most important point that we have to make, because you've got to give craniospinal radiotherapy, and that's a very toxic treatment. We know these patients survive for quite some time. Amit's patient was a classic example. There was pachymeningeal involvement and that patient has gone on to receive TDXT. So this patient is again a classic example. In spite of having persistent CNS positivity, patient is still doing well. Quality of life seems to be good. So we would prefer not to give craniospinal radiation therapy for somebody with leptomeningeal disease. I think that's the most important point. Try as many systemic therapies as possible. Try new things like intrathecal trastuzumab and so on and so forth. So I think those would be the learning points from this very nice case from Rajiv Gandhi Cancer Hospital. So if we can move on to, I'm sorry, that was an India slide. Anyway, never mind. I think we've gone through that list. Can we ask Kanupriya to present the next case, please? So Anindya is the odd man out. All the others are ladies. Dr. Kanupriya, are you ready?
Just starting.
Unmute.
Yeah, sure.
So I'm presenting a case of Mrs. M, 44-year-old premenopausal female, who presented in 2021 with a lump in the left breast, and the mammography was suggestive of Byrad's 4. Okay, so the patient had Byrad's 6 lesion, and the patient was presented outside in a private hospital. She underwent an upfront left MRM and an axillary lymph node dissection. The pathology was a PT4B N3 disease, and post-op the patient IHC show 13 out of 15 lymph nodes were positive. It was ERPR positive, HER2 negative tumor with a Ki67 of 50 to 60%. A post-op PET scan was done, which was suggestive of multiple sites of metastases, including left chest wall deposits, multiple regional and non-regional lymph nodes, bilateral nodules in the lung, and multiple skeletal metastases as well. This is when the patient presented to us, and the patient was we started her on medical ovarian functional suppression along with palbociclib and anastrozole. And unfortunately, like the patients that we've read about in trials and we see in our OPD, the patient just had a PFS of 3 months on palbociclib and anastrozole. And then she progressed. She was symptomatic as well. She had cough and dyspnea. We did a CT scan, and at that time, the response scan was suggestive of frank progression of the disease with bilateral increasing lung nodules. This is when we started the patient on paclitaxel. Post 4 cycles of paclitaxel, though she had a clinical benefit, but the CT scan was suggestive of progressive disease. We discussed the response scan from with the tumor board, and there was a confusion whether this would be metastasis. This is actually not the scan of the response scan. This is the baseline CT scan. The progression scan, actually the slides are being, the progression scan, yeah, this is the scan. So there was a confusion whether this would be metastasis or infection. So because the patient had clinical benefit, we continued with the 5th and 6th cycle of paclitaxel. And till then, we also referred the patient to pulmonology department for an evaluation. Patient underwent BAL, which was negative for all the common pathologies. And we did a CT-guided lung biopsy also. The CT-guided lung biopsy here was suggestive of, again, GATA3 positive tumor, which was again ERPR positive, HER2 positive. So after 6 cycles of paclitaxel, we then changed, because the patient was again symptomatic, we changed the therapy and started the patient on just a second. We started the patient on EC chemotherapy. Post 4 cycles of EC, now the patient again has clinical progression. She has increase in chest wall deposits and a new left supraclavicular lymph node also. So the point of discussion, so we have here a 44-year-old case, hormone positive, HER2 low, metastatic breast cancer with primary endocrine resistance, and is post CDK4/6 inhibition, anastrozole, taxane, and EC chemotherapy. She is not affording, she has financial constraints, which is why we did not go for mutation analysis till now for PIK3CA. So the point of discussion here is what would be the ideal course ahead for this patient and what further options do we have?
Excellent. So that's a typical situation that we come across, hands tied, constraints in terms of getting tests done and therapies, but you have to continue to treat because patient's performance status continues to be good. So Chirag and then Ullas, what would be your choice for treatment next? 44-year-old, lung metastasis at this point in time, paclitaxel, EC progressed primary resistance to CDK4/6 plus hormonal therapy.
This is clearly a hormone-resistant disease, and I won't try any further hormone for this patient. That's the first thing. Second thing is that if we accept the resource constraint and if we have to go ahead with the available treatment, maybe capecitabine, eribulin, and so on and so forth. But if we look at the ideal situation where I would want to have done an NGS to look for something like Antract, which would have helped this patient. PIK3CA could not have helped this patient because this is a hormone refractory patient. So there is one thing. And if nothing comes out of NGS, maybe looking at HER2 1+, we could use TDXD, or there is a data of sacituzumab govitecan in hormone receptor positive patients as well. So these are the few options that we could exercise for this patient.
Ullas?
So what I'll do is give capecitabine. I mean, in a resource constrained setting, that is one thing, and we've seen some decent responses with capecitabine. On a theoretical level, yes, do an NGS and BRCA and everything, but very unlikely to really respond to. And again, HER2 1+, so we can try with TDXG also.
Sacituzumab, what are your thoughts on that in HER2, in ER positive disease, Ullas?
Not really, not really. I mean, TDXG would be more better.
TDXD would be better in patients with ER positive disease. So I think you're looking at everolimus and fulvestrant, capivasertib, fulvestrant. Do you think these choices would figure somewhere, or do you think these are not?
Right now, the volume of disease is more. I would probably go for capecitabine first, and then everolimus and exemestane.
But the response rate to single agent capecitabine with such high volume disease, it's about 10-15%, as we discussed earlier. So, one thing that I don't find in this list, but I would be very tempted to use in a 44. So it's either hormone resistant or it's not. Not PIK3CA. It's probably, not typically behaving like an ER positive disease. It's a young lady. So one of the thoughts that I have is it one of those basal types of cancer that's just expressing these receptors? So for me, I would use combination chemotherapy, something like gemcitabine and carb. One of those, because it's a young lady. I don't think you will get 3 more chances to treat this lady. You will need to put your best foot forward in this particular situation. Yes, all of us would love to do one of those ADCs, but with resource constraints, I don't think you will get a chance to do that. So for me, the lowermost of the choices, chemotherapy is what I would look at. BRCA mutation testing is very much on the cards, but for me, a poor lady's BRCA is poor lady's olaparib is carboplatin. So even if I found out a BRCA, and if I cannot use olaparib, which is the case in this situation, I would probably fall back upon carboplatin. So I would probably, in theory, in reality, approach this like a triple negative disease rather than like an ER positive disease because of the resistance to hormonal therapies. But as Ullas pointed out and Chirag pointed out, it will be good to get an NGS for me to learn at least why she's so resistant to all the endocrine therapies, the best endocrine therapy at least that we have. So it will be a learning experience. But as Ullas again pointed out, whether you will really get something that you can act upon is $1 million question. So we really don't know the answer to that.
Senthil, Amit here.
Please, Dr. Chirag, go ahead.
No, Amit speaking. Just a question. So, Senthil, would any of these patients like ER positive and triple negative as progressors would ever get bevacizumab in your practice in combination with chemo?
Not really, Amit. So would not. So there's only one patient I have done that, and unfortunately it has failed. So I have done that following, especially in a situation where you're using taxane. I would be tempted to do something like that, but not in a situation like this where you use taxane, where you use epirubicin, and in a late line using bevacizumab. I'm not too sure. I wouldn't do that.
Okay.
Triple negative patients with effusions, I might do that. That works.
Okay.
It's not a great fan of bevacizumab anywhere, definitely, and not in breast. That is one. Capecitabine, somehow I've got a very good experience, and the patient likes it, and we like it. Oral medication, patient doesn't really have to come to the hospital. So that is why probably capecitabine would be my first choice again, and then GemCarb definitely is on cards in the practical world.
But I think we need to sequence those therapies in a way that's appropriate depending upon the clinical situation, I suppose. So for people who are listening, I think sequencing is very important. This typical patient that all of us would see, resource constraint, can't have everything under the sun, and we still have to manage. So in this situation, you have a list of chemotherapies that you can fall back upon and try to use them one after the other. Remember that these diseases, which are rapidly progressive, don't give you, 6 lines of treatment to use and so on. So you may have 2 or 3 lines. So use your options judiciously so that you can get that survival to prolong as much as possible. Yes,
again, last point. Again, a cliche statement, but talk to the patient. What do they want? Absolutely. And very important is to discuss this, whether oral versus IV, and what do they really look at. I mean, that's very, very important.
Very, very important. That's a point always. Irrespective of what situation, whether you've got 100 choices or you've got 0 choices, it's important to talk to your patient and make sure that he or she is a part of the decision making. Lovely. So those are the learning points in this case. A very practical case, should I say? Can we have the last case, Devanshri?
Good evening, everyone. So, am I audible?
Yes, absolutely.
So, my patient is a 60-year-old female, initially diagnosed with stage 2 ERPR positive, HER2 positive CA breast. Initially received NACT with 12 cycles of weekly Pecli plus trastuzumab, underwent surgery, achieved PET-CR, and then she completed adjuvant chemo with 4 cycles AC, followed by 1 year of Pecli plus, 1 year of trastuzumab plus pertuzumab. Followed by which she had good PFS. She relapsed after 5 years and now with liver mets. So liver biopsy was also HER2 plus, showing HER2 plus 3. She was started on trastuzumab plus pertuzumab plus docetaxel, received 6 cycles, achieved PR, and she was continued on maintenance H plus P. So again, she had a good PFS of 3.5 years, and she now progressed with liver mets and lung mets. MRI brain was normal. So points for discussion for this patient for further management: do we add Taxane as this patient had good response, or do we change to TDM1 or TDXD or HER2 climb regimen? And role of screening MRI, if there is any role, presence of brain mets, does it make any difference in management?
Okay, so Chirag, can you take question number 1, something that Ullas suggested for the atezolizumab patient, 3 years, lovely PFS. So there's something making this patient very addicted to the HER2 pathway. Would you add a taxane and continue H plus P?
So, yeah, that's one of the possibility. And we have one small publication in Annals of Oncology of 2017, where 4 patients were treated by reintroduction of Taxane, and 3 out of 4 responded. But, the patient initially had a recurrence after 5 years. And then after 3.5 years, patient again had a recurrence. So I was just wondering, this patient is ERPR positive as well. So why not to add something like Pertain trial while a dual anti-HER2 with a hormone, or something like alternative trial where trastuzumab, lapatinib, and a hormone. So that's one thing, because patient has remained progression-free for a long time.
Okay, good point. So why didn't you add some hormone? Was it any reason, Devanshi, that during the H and P maintenance, no hormone therapy was added? Any specific reason?
So, it was 3/8. Scoring was 3/8 only for ERPR.
But wouldn't that qualify for treatment with hormones? Okay, for some reason you decided not to do it. But the general rule is that even if it's 1%, we would put them on some hormonal therapy for whatever it's worth, it isn't it? So never mind. Anyway, that's all right. So that would have certainly been a choice during maintenance treatment. That would have maybe prolonged your PFS by a certain amount of time, I believe. Ullas, you wanted to say something. Go ahead.
So definitely add, and definitely patient should have been given hormones during the Herceptin and Perjeta regimen. I might just consider adding. I'm a big fan of capecitabine in CA breast. So if the finances is a concern, I mean, the Perjeta would have been given free to this patient by now.
For 36 months, so finance cannot be.
No, the Perjeta would be free now. No.
Okay.
so I mean, to a very on a very practical level, I would probably give Perjeta plus trastuzumab plus capecitabine. See how it goes. But if I have to answer a theory question and if I have to answer a panel question, I'll go to either TDXD or a TDM1. Brain mets definitely is a deciding factor. When tucatinib gets available, brain mets positive, go for tucatinib, Herceptin, Xeloda. It's negative, go for this. So I mean, right now I would give either TDM1 or TDXD if it's available. Very tempted to add capecitabine to Herceptin and Perjeta right now.
Keep it on because patient has done so very well. So Ullas, you made the point regarding tucatinib, since we won't have time to discuss brain metastasis later. Yes, again, in theory, you're right. But as was pointed out earlier, the amount of data on untreated brain metastasis or brain metastasis that have been treated and then progressing, for whom radiation is again not an option. The data that you're getting with TDXD is also good, but
it's good. It's good.
Sets of patients, 9 patients, 18 patients, and so on and so forth. So my question is, if this patient is progressing systemically and also in the brain, with the available data with TDXT and the superb survival that you're seeing in the Destiny study compared to TDM1, would we want to rethink on that strategy of using tucatinib for everybody with brain mets?
Absolutely right. Also depends upon whether the brain mets are symptomatic, asymptomatic, probably, and what's the volume of disease which is progressing extracranially. So I think ultimately TDXD might just hold an edge in an asymptomatic, very low volume disease. One small, read the report and look at the films also. And, today I just saw a patient who had progression in the brain with 7 into 2 millimeter lesion. Just don't look at the final link of the report. Look at whether it's symptomatic, asymptomatic, where the location of brain mets is. TDXD for me is a fantastic drug for that also.
Right. So the reason, I think over time this algorithm will change. Yeah. Will continue to be dynamic because the more data you get with TDXT in patients with brain metastasis, the more likely that it's likely to, push
displace
away. But at this point in time, whatever Ullas is saying is absolutely right. The algorithm says that if you've got brain metastasis, then you might want to consider capecitabine, trastuzumab, and tucatinib in that patient. But my question there is, if you look at the HER2 CLIMB study, these were patients who had H+P. Almost 100% of them. More than half of them had already had TDM1. So here is a situation where you're going to change from H+P to capecitabine, H, and tucatinib. So I'm a little uneasy in a situation where somebody has progressed on trastuzumab and you're keeping that trastuzumab and adding capecitabine and tucatinib. I might as well do only capecitabine and tucatinib rather than doing trastuzumab because somebody has progressed on that. So Chirag and Ullas, quick comments on that point.
So, Senthil, before we go to that point, I think I want to answer the last point. If brain metastasis is present, can we avoid RT? Yep. If there are multiple brain metastases which are asymptomatic, avoid RT and give one of the CNS active drug. If there are up to 3 metastases, someone may say up to 5 metastases, less than 3 centimeters, you can give stereotactic radiotherapy to each of these metastases. That will keep the patient better for a longer time. And now coming to the question of whether trastuzumab to be added to tucatinib and capecitabine or not, I think the data of HER2 CLIMB study says that trastuzumab works in this situation as well, because most of these patients were treated with trastuzumab as well. So I will not want to deviate from the data of that study. But yeah, intuitively what you say is correct, that tucatinib, capecitabine also could do as well.
Ullas, since you do a lot of lung cancer, my question is...
Was this a very sarcastic comment, Senthil?
I didn't mean anything like that, Ullas. I will never. So tucatinib, trastuzumab, capecitabine gives you a 44% response in the brain, right? Not huge by lorlatinib or alectinib standards. And, even in a situation where you've got drugs that are so good in the CNS, we still are sometimes a little shaky in not doing radiotherapy. In fact, when I did a panel recently, we had a show of hands and asked if patient is asymptomatic with brain metastasis and you've got tucatinib, would you use tucatinib or would you radiate the brain? And I can tell you that most people still said they will radiate the brain, because I think that confidence to put patient on a drug that's got a 44% response rate, that is good, but we would not call that huge by any standards. There's still a lot of hesitation, and I very much agree with that thought process that it is impressive, but I wouldn't call it as impressive as the lung cancer drugs to be able to totally give up radiotherapy. So like Ullas said, you've got a 7 millimeter, a 9 millimeter, and so on and so forth. It's all right. You've still got time in your hands. You would wait. But if you've got somebody something that's, a 2.5 centimeter, 3 centimeter, I would be very nervous to put my money on tucatinib and avoid radiotherapy. Ullas.
Absolutely right. I mean, as I said, look at the scans, look at the things. And again, as Dr. Chirag said very rightly, whole brain RT is something which I'm against of. CyberKnife, SRS, SRTs is something which we should consider more and more, and then couple it with the systemic therapies. Tucatinib 44% good, but not mouth-watering.
Absolutely. Not mouth-watering. So you get a 67% complete response rate in the brain with lorlatinib. Right? Nowhere close to that. So lovely drugs. But I think we'll get better as time goes by. So I think we'll wind up this case. So the learning points here are that if you've got somebody who's gone on for a long period on a particular drug, You may go back to chemotherapy and continue that targeted therapy. However low your expression of ER is, that patient would still be a candidate for maintenance therapy with some hormonal agent, with or without the targeted therapy, depending upon what that clinical situation and the phenotype is. These drugs, these new drugs for HER2 positive disease, TDXT or tucatinib, neratinib, and all of them have reasonably good CNS activity, but not to a point where we can say, no problem, don't use radiotherapy. All of these patients can go on these drugs. So one has to use a lot of judgment and take your patient into confidence, as Ullas was pointing out early, before you say, I don't want to do radiotherapy, I'll put my money on tucatinib or TDXT. So you need to be very, very careful and cognizant about the data before you really employ it in clinical practice. So I think those would, for me, be the learning points from this case. But as usual, a very nice case from Tata Hospital. So if there are no more points, I'll quickly run through. Yeah, Ullas, you wanted to say something before?
No, nothing.
Okay.
I said the 6 cases from Indo-American. We would like to hear that also. A short presentation.
Yes,
2 minutes. From the horse's mouth.
No, that's from Dr. Divya's mouth. So if you want to call Divya. So on popular demand of the audience and AZ, they've requested Chirag and Ullas to be part of the panel also. So if I may request both of you gentlemen to stay there. After I call you both of you gentlemen and stay there, I don't think you can get off your seats. Both of you please sit there. So I'll call Divya to quickly run through our case.
Good evening, all. This is a 37-year-old lady present.
Can you hear Divya?
Yeah.
Okay, lovely. Okay, Divya, go ahead.
37-year-old lady presented in 2014 with right breast lump, clinically CT2 N0M0. Biopsy suggestive of invasive ductal carcinoma, grade 2. ERPR was strongly positive. HER2 is equivocal. FISH was positive. She received NICT with 4 cycles docetaxel trastuzumab and 4 cycles CC, underwent BCS and adjuvant RT. HPA was IP-T1N0. She received adjuvant tamoxifen and trastuzumab. Germline HPOC panel was negative. She was on follow-up for 5 years, after which she was lost to follow-up. Now presented in 2023 with severe back pain. MRI showed suggestive of metastasis. PET scan was done, which was showing multiple subpleural and parenchymal lung nodules, largest measuring 5 into 4 centimeters with mediastinal nodes, hepatomegaly with multiple liver lesions, largest measuring around 6.5 into 5.5 centimeters, SU max of 10. Lytic lesion with soft tissue component in the right clavicle, so multiple dorsolumbar vertebral mets, sacrum and both pelvic bones with partial collapse of L1 vertebra. CBP biochemistry was normal except mild elevated alkaline phosphatase. She underwent repeat liver lesion biopsy. IHC for ERPR was strongly positive now, and HER2 new is 1+, FISH was negative. K67 was 60 to 70%. IHC for GATA3 was positive. Question: as you know from ISMPO, like if there is a disparity between the primary and the metastatic IHC, if anything is positive, we have to treat like a positive disease.
So what would you do in a patient like this, Ullas, or Chirag, or any one of you, Amit? Because here is a patient who's come back nearly 10 years after the initial presentation. She's got liver, she's got lung, and she's got bone metastasis. ERPR is strongly positive, and the HER2 is negative now. It was positive at the time of diagnosis. So there are no clear guidelines on how do you go about here, and there are no large volume studies telling you what is to be done. So how would you make your decision regarding which direction to take in a situation like this? Is it the HER2 direction because it was positive initially, or would it be the hormone direction because that's strongly positive now? So how do you really decide? Ullas, can we start with you?
Okay, so this patient had taken trastuzumab for a year and tamoxifen for how much?
5 years, and then we lost for follow-up. For the past 4 years, we didn't see her till she came back with some back pain now.
And how much is the performance status right now?
PS is 2. It was 3 when she came in. That was because of back pain. She was wheeled in, but after radiotherapy, she's up and about.
And no visceral crisis right now.
No visceral crisis, no impending visceral crisis also.
No, rightly said, no impending visceral crisis also. Okay. In this particular patient, the biopsy has been done ERPR positive, HER2 1+. I would be tempted to start on a hormone therapy itself, although the dictum says that you have to go and follow the initial report. But you have an oral option available. I'll do a quick, normally we do a scan after 4 months of starting an hormonal therapy. In this patient, I might, if the patient is not responding and this thing, I may do it a bit earlier. But, and I will recheck the initial specimen also for a HER2
So the reason
and,
why we did check Ullas is because it's nearly 10 years, so I wouldn't rely upon that block even if I did testing now. I wouldn't rely on that result, I would say, rather than.
Since an oral medication is available, I would like to give her CDK4/6 inhibitors and a hormone therapy.
Okay, so what is the situation where you would say, I want to take the HER2 positive route?
So let's say this patient had taken trastuzumab, comes back within 2.5, 3 years, and that biology of disease it is showing, then I would rather go that way.
Okay, so
my point right now also is, Senthil, if you didn't really have to trust the latest report, why did you do a biopsy?
We do trust, but the reason why I put up this case for discussion is because there's no clear guideline on which line you need to take. So that's the reason why I put this up for discussion.
For me, hormone therapy, the biology of the disease coming back in 10 years' time, a patient being PS2, I would rather go for CDK4/6 right now.
So the point was that she's got liver metastasis, she's got lung metastasis. So though it was a very late relapse, there's visceral disease as much as there is bone disease. So that was another thought process to discuss whether you should go the chemotherapy HER2 positive route, do that, and then put your patient on hormonal therapy as maintenance, which we were discussing earlier. Anyway, never mind. There's no one right answer. So that's why we're discussing it today. Chirag, and then can I call upon Vineet? Chirag, and then...
So, Senthil, as it was written in the right lower corner that whether to chase another site of disease for a biopsy again, the answer is no. I mean, it has been almost 10 years since the last trastuzumab therapy, and now if this is the report, I will believe it. Now, this is the correct candidate for right choice kind of therapy. It is not visceral crisis, but it is impending visceral crisis, I can say, looking at the volume of the disease. And looking at this volume of the disease in the liver, the CT scan film that you are shown, I will be tempted to give chemotherapy to this patient. And I agree with Ullas that if there is no real visceral crisis, we can do with hormonal therapy as well. But the disease volume looks to be too high for me, and I will want to give chemotherapy followed by hormonal therapy as maintenance.
So is it chemo plus anti-HER2 therapy or chemotherapy alone?
No, chemotherapy, no anti-HER2 therapy.
But the guideline says that if you have positivity at any point in time, you will consider it as positive and then decide what to do. So
it was a decade earlier. I don't think I will go with that report too strongly.
Okay, so you won't go through that report very strongly. Vineet, you muted yourself. I hope. Amit,
I'm sorry. I had some network problem, so I think I missed the case. So I'm sorry.
Okay, never mind. We will, take your comments for the next case. Amit Rautan, if you're around, what would you have done in a situation like this?
So I think this is where I kind of think biologically we would go with the HER2 negative status because of the way the history is. But I personally believe this is where NHER2 will change the whole course. And I personally believe why TDXT, why our Destiny Best 3 is so positive is because of this reason. When you have TDM1, you need it to be clearly positive. And a lot of patients in the relapse, they actually lose their HER2. In breast, we don't chase it. We don't really chase it. And we say the first positive is positive forever. And we treat it. And that's why probably TDXT was doing so great for all these patients because some of them would have lost it and become 2 and 1. So I think in future, these are the ideal candidates for NHER2, and that would be the best drug for it. But practically, if you ask me what I would do at present, I would clearly agree. I would go with CDK4/6 hormonal, watch very closely in the first 3 months. If they respond, we would continue that. And if they don't, then we probably do another biopsy and look for heterogeneity. So do you think there's a role of doing an NGS and looking for HER2 amplification here?
Okay, so
would it show up?
brought up that issue. So for me, I think I look at it like this, Amit. So if the receptor is lost, I'm a little nervous putting them on any of these treatments, which are antibodies, which are very much dependent on that receptor for whatever activity it is. So even if I do an mRNA analysis and then let's say we do a Prosigna and then it comes back saying this is HER2 enriched, I would still be a little nervous in putting this patient on an anti-HER2 therapy, because if the receptor is downregulated, we know that these are resistant to these anti-HER2 therapies, and there's data to actually support that. But that is something that we always need to consider doing. And as you rightly pointed out, that will be a situation where even if it's low, TDXD can, still have some activity. So for me, I considered all these pros and cons, and then we sat with the patient, discussed. She was just 44-year-old, whether to put her on CDK4/6 plus hormonal therapy and of course ovarian function suppression. After a lot of discussion, I went back to do chemo plus trastuzumab. That's what I have done for this particular patient, because I felt, as Chirag felt, there was a lot of disease, especially the bones were actually riddled with disease, and liver showed significant disease and the lung showed significant disease. So I was a little nervous to put this patient on a CDK4/6 and wait, because if the CDK4/6 didn't work and then she deteriorated, then you don't have another chance to treat, was my thought process. Of course, but all the points that you guys have made are absolutely valid. We really don't know which way to take. We would take the clinical presentation so much into consideration before we make a decision on whether you go the HER2 way or whether you go the hormone way. So it's going to be a question of your judgment. But I would disagree with Chirag that we would not use an anti-HER2 therapy, because at some point in time we would use it. If you don't use it with a CDK4/6, plus a hormonal therapy now, at a later point in time when I decide to switch to, systemic chemotherapy, I would certainly add an anti-HER2 therapy at some point in time. That brings us also to the question of, when would you do a monarch-HER kind of a strategy? Let's say you decided to start with CDK4/6 and a hormone. Would there be any merit in adding HER2 therapy also in a situation like that? Vineet, can you take that question? So let's say we decided to do, so Vineet, this is a patient who had loss of HER2 when this patient relapsed after many years. So the discussion here is whether you should put this patient on an anti-HER2 therapy straight away with chemotherapy, or should you do hormonal therapy and then decide on the anti-HER2 therapy later? So is there a role to do hormonal plus anti-HER2 therapy upfront? What are your thoughts on that? Chirag spoke about alternatives and pertain and all those data earlier.
Yeah, so ideally, if you're going to start some kind of anti-HER2 therapy in such a case, you'll initially start with some kind of chemotherapy in combination. Okay. So I don't think it's going to harm the patient to add hormone therapy to that combination. But the problem will be how to, integrate CDK inhibitor with that.
Right.
By taking care of the toxicity. So I think, I know the conventional wisdom is not to give hormone therapy with chemotherapy. But I think in such a high volume kind of or complex kind of case, you can give them together. But I'm not sure whether you can add CDK4 inhibitor with that.
Okay. So Dr. Dowell, Ullas, is Dr. Dowell around?
No, he's not.
He left. She told me that he may want to actually leave. Okay, never mind. So
I think Dr. Dowell has joined virtually from somewhere else. I'm not so sure whether he can answer on that platform.
That he will leave a little early, and that's why I'm asking you whether he was around or not. Anyway, never mind if he's not there. That's perfectly all right. Atul Batra?
I don't see him.
Okay, never mind. So we have a very diverse set of opinions on a case like this, and that's why it makes this very interesting. Everybody's got their own opinion. One would ignore the HER2 status completely. One would do hormones. One would look at using TDXT very early. Vineet said he would want to do chemo plus hormone. So you see that 4 different opinions from 4 people. So it just tells you that there's no one right way of managing this case. I think it's a question of what you discuss with your patient, what you think is best for your patient, and proceed on that line. I'll quickly take you through. So this is what I was alluding to, Chirag. So it clearly says that since a clinical trial addressing this issue is difficult to undertake, we recommend considering the use of targeted therapy when receptors are positive in at least one biopsy, regardless of timing. And that's the reason why I decided to go ahead with the anti-HER2 therapy along with the chemotherapy. So this is one case, and then we'll stop here. So this is a 59-year-old lady with a newly diagnosed left breast cancer with liver metastasis, right? So you see the liver metastasis, 2 cuts of the liver on the right side. So the biopsy was grade 2, 60% ER, 40% PR, and the HER2 was 1+, no comorbidities, no family history. Like everybody would do, the thought was to put this patient on CDK4/6. And then we have a NGS report that is done. And the NGS report comes as PIK3CA that is positive, and you've got 82 copies of FGFR1. And below, you see that the TP53 is actually mutated, and it's a likely pathogenic mutation. Though we would all agree that, at least I assume so, that we would all agree that this patient should go on a CDK4/6 plus hormonal therapy. Would this NGS report make you a little nervous because this has got a lot of negative predictive markers for the activity of palbociclib or any CDK4/6 inhibitor for that matter? What would you think? Agreed that we would put this patient, this should not change the way we are managing our patients at this point in time. But the markers that we are seeing, Amit Rautan, I'm sure you do a lot of NGS much more than any one of us. So would this report make you a little nervous, patient on CDK4/6 plus an AI?
Yeah, I agree with you. The mutations which you are showing are a little worrisome, especially the P53 is making me worried. And I think the FGFR also is making me worried because we know these are mutations for CDK4/6 progression. But I don't think I would change my practice. The only one for which I really get very nervous is if I start off with an RB loss. That worries me for putting a patient on CDK4/6 upfront. But the rest of them, I'm pretty okay to start off with. But I will tell the patient we'll do a close watch. Maybe look at them in 2-3 months and see whether it's working or not. But I would still go the same way first line.
Absolutely. So Ullas, would you agree with that you would get the CDK4/6 way, but then you will keep a close watch?
Agree with that, and I will not send an NGS.
You will not send an NGS. Lovely. So to substantiate...
Why did we send an NGS?
We send an NGS because if I don't send, the patient will come to you and you may end up sending it. So that's
I will not send.
So that's a good point that Ullas has actually made, but we end up doing these tests for various reasons, academic, non-academic, and so on and so forth. So the reason why what Ullas is saying makes a lot of sense, but sense and more sense and less sense is because of these recommendations. The one on the right is the ASCO recommendation for the biomarkers that you're supposed to be doing. The one on the left is the SCAT recommendation. That's from the ISMPO. You see that apart from PIK3CA and a germline BRCA, you're not expected to really do any of these upfront, though many of us would do these tests. And you see on the left is another list that's showing the list of things that you may want to do. Again, it's not very different from the table on the right. So though we end up doing it, and I did it, and this made me very nervous, and my nervousness was well-founded because very soon this is what you saw, and this patient had progression on the first scan that was done 3 months from the time that we started CDK4/6 and an AI. So I think this is important to keep in mind. As Amit said, that's what I do. If I find somebody like this and I did an NGS for whatever reason that might be, I'm a little nervous with the CDK4/6 inhibitor. And that's what the data says. If you have an FGFR that is amplified, your PFS on a CDK4/6 inhibitor is somewhere around 7-8 months compared to the data that you would usually do, which is about 24 months. So we need to be clearly cognizant of this. The reason why I'm showing you all this is because our panel discussion was titled Personalized Medicine and ADCs in the Era of Personalized Medicine. This is something that Dr. Sunil Verma actually alluded to during the course of his talk. Early change to fulvestrant based on on liquid biopsies and the appearance of an ESR1 mutation. This is a study that's relatively old now. It is 2020, but something that we have not adopted, although the PFS that you see in this, which I put in that small box down there. So what they did was patients were randomized to either change from a CDK4/6 plus AI to fulvestrant and continuing the CDK4/6 inhibitor, or just continuing irrespective of what you saw on the NGS, if they didn't have a radiological progression. Because if they had a radiological progression, obviously you would change to fulvestrant plus, alpelisib, everolimus, or one of those drugs. And if you just changed from an AI to the fulvestrant based on the appearance of an ESR1 mutation, you got 5.5 months extra, right? Which is not something that you get even with the best of drugs now. So I want to ask Amit. Amit, you pointed out earlier during your case presentation that you tend to do a lot of liquid biopsies. And you also said you saw the appearance of an ESR1 and then the ESR went down, it came up and so on and so forth. So is this a strategy that is very attractive to start using? Though there are a lot of problems with a strategy like this, but what would your thoughts on that, Amit, be?
So, Senthil, very conceptually really good because you know ESR1 would be resistant to AIs and you want to continue it. But we saw the drawback coming from this. We saw it that you have this doubling of PFS if you changed before, but you also have the third presentation which came out in last year, which we saw that if you did the same thing when they clinically progressed and then changed it, you had a benefit of only 2.5 months. So really, you're not losing out much by going by the clinical way also. This benefit is there, but even clinically, you have a benefit. But yes, I think the future is going this way. Whatever we say, the future is this way because all the new trials are being designed this way. So eventually, it is important to catch an ESR1 mutation early. And I think in all the future new trials, this is being looked at.
Ullas, is this something that looks attractive, not necessarily for adoption tomorrow morning? But for me, it looks a little attractive. But they've done liquid biopsies every 2 months. Not very easy now setting. If you want to do a Guardant every 2 months, it's about 2.5 lakhs every 2 months. So that's not easy. And also, we have not clearly shown that a strategy like this gives you a better overall survival. Considering the long survivals that you're seeing in ER positive disease now, we've touched 60 months now. But, in the short run, does it look attractive?
It looks attractive. I think in short run, it doesn't look attractive. In the long run, when the liquid biopsies will become rampant and, we'll have standardization of techniques and Guardant will not be the only one which will be doing this, we may do it. Right now, I'm slightly skeptical of changing my management decisions only on the basis of liquid biopsy reports right now.
Absolutely.
In the long run, when everything, when we'll have more confidence. Remember, Senthil, when NGS came in, we didn't know how to interpret that. Today, we're good with NGS. Liquid biopsy is coming up over there. Maybe in 5, 6, 7 years, but slightly skeptical of changing on the basis of only only a liquid biopsy report.
You're good with NGS, Ullas. I'm very bad with NGS.
Modesty, your middle name is Senthil Rajappa.
Okay, never mind. Ullas and Amit are absolutely right. We have not clearly demonstrated consistent benefits. There are a lot of pitfalls in the way we are doing this. Which of the ESR mutations should you be picking up? How frequently should you do? How early should you change? I think there are many questions unanswered. And Dr. Verma, during his talk, spoke about the Serena study. Serena study is doing something on these lines. The other question, Chirag, is we have these oral SERDs. And oral SERDs compared to fulvestrant is showing some benefit in patients with ESR1 mutation. I really don't know, again, biologically, how to explain an oral SERD working better compared to an intramuscular SERD. Is there any way of explaining this happening? Chirag and then Vineet Gupta, both of you, what are your thoughts on this?
No, there is no, you can explain the better efficacy of oral SERD as compared to intramuscular SERD, except having to believe that oral SERDs are more potent as compared to intramuscular SERDs. No other explanation.
Okay, so there's no other clear explanation. Vineet, do you have some biological explanation as to why an oral SERD should be superior to an, a parenteral SERD?
Yeah, so these are all rationally designed molecules. So probably they have been designed to be more efficacious compared to fulvestrant. So probably that's the only thing which I can think of.
I don't know very clearly what the reason should be, because that's something that keeps, coming to my mind. Why should a drug with the same mechanism of action work better orally, compared to when it's parenteral? There must be some character of the oral SERD which is making it work better. Right, guys, so it's 8:15. I don't want to keep you away from going home and watching your Netflix. So I will stop. There are many other things that I would want to discuss, but for want of time, I will stop here. Are there any final points that any one of the panelists want to make? I'm sorry, we had to cut short this down because we had some lovely cases presented by all the centers. And I hope we learned something from all these cases and we are wiser and better at the end of this evening than when we started at 6 p.m. Ullas, Chirag, Amit, Vineet, any one of you would want to make a closing remark before I hand it over back to AZ?
Yeah, so I had one very small point.
Yeah.
So, with CML, you have a monitoring of BCR ABL, which is done very easily. And, when you see that patient is losing their landmarks, you have an early change of therapy. So I think a lot of solid tumors might go that way over time. So PATHA-1 trial is just like an early signal towards that approach. Definitely when it is as cheap as a BCR ABL test and as easily available, I think that will change things.
And more importantly, as standardized as a BCR able test, which is, I think, the most important part of this, because you have umpteen number of labs. There's a mushrooming of labs, and as clinicians, we really don't know which is good, which is not, and we need to get some knowledge about how to assess the goodness of a test. Because when BCR able started, we didn't know how to go about assessing. Then they said you look at the able copies, how much is it standardized, is it got an IS, and so on and so forth. So like that, I think we should get some standard ways of assessing how good or bad a particular test is. But your point is very well taken. I think doing these in the blood will precede radiology, and hopefully we will get more effective options so that we have an option that you can use to change treatment early, and hopefully that will end up prolonging the overall survival of our patients with good quality of life. I think that's very, very important. Jumping to a therapy is important, but maintaining quality of life is even more important in all situations where you can't cure. Guys, anything else? Or we have spoken enough?
So, Senthil, last point.
And my point would be this is a much better way of learning, actually, and rather than the stupid old normal moderation that we keep on doing, real life case scenarios with people coming around and giving their opinions is fantastic. So thank you for the learning. Thank you, Senthil.
Thank you, Ullas. You're always very kind to me. Chirag.
No, it was good. I mean, no further points from me. Thank you very much for this wonderful moderation.
I wish AZ had got a slightly better picture of me, right?
For a change, I'll agree with that. Can we all pose for a photograph with this, so that we can keep it, and next debate we can use it, Senthil?
One resolution I've made, Ullas, not to debate with you. but I'll never, we had such lovely times. I hope, we will do that again. Excellent. So, that banter will keep continuing. I think we'll stop here. I'll hand it back to Sana. Sana, thanks. AZ, thanks. ISMPO, thanks for asking me to do this. So Manthan GI is coming. There you are. Amit Rautan, the star, is going to be the program director for that, and we look forward to that. Thanks so much. Back to Sana.
Thank you so much, sir. And thank you, everyone, Dr. Batra, Dr. Amit Rautan, Dr. Chirag Desai, for spending your Saturday night in this session. We hope to see you next with Manthan GI. Dates are yet to be finalized, but once it's finalized, we'll come back with you with dates. Thank you so much. Good night and happy weekend.